morning, everyone. Happy November. We'll be starting our journal club. I hope everyone's having a good month so far. So because it's 7 a.m., we'll be starting the Orlando GI Journal Club. So I've chosen 4 studies today. The first one is published in Gut. It's a study from South Korea looking at the association between proton pump inhibitor use and gastric cancer. It's a population-based cohort study. This study is important in our clinical practice because gastric cancer is the 6th most common cancer worldwide, with the highest incidence in East Asia. H. pylori infection is the strongest known risk factor for gastric cancer, but long-term PPI use can accelerate or induce the progression of corpus gastric atrophy and lead to hypergastrinemia and therefore increased risk of gastric cancer. The aim of this study was therefore to look at the association between PPI use and gastric cancer in the general population and H. pylori eradicated population using nationwide databases in South Korea. So this was a nationwide population-based cohort study using the Korean nationwide cohort database. They looked at data from 2002 to 2013, and the study comprised over 11,000 patients in matched PPI and those in the non-PPI groups. The median follow-up was 4.3 years, and the primary outcome was to look at the incidence of gastric cancer more than a year after drug exposure. They looked at the incidence between new users of PPI and non-PPI drugs. So this is the study results. So they looked at the association between PPIs and gastric cancer in the general population and in patients known to have been treated for H. pylori. So as you can see, when they looked at the incidence of gastric cancer in patients not taking PPI, compared to those taking PPI for more than 30 days, the hazard ratio was 2.37. With p-value of 0.001. So this means that patients who have been taking PPI for more than 30 days was associated with more than twice the risk of developing gastric cancer. They also looked at the association between duration of PPI therapy and gastric cancer. And as you can see, the hazard ratio for developing gastric cancer was 3.5 in those taking PPIs for more than a year, compared to 2.83 in those taking PPIs for more than 90 days. When they also looked at patients who have been treated for H. pylori, known as the H. pylori eradication group, they also found that in patients who had taken PPI for more than 6 months and more than a year, the hazard ratio for developing gastric cancer was significant, with hazard ratios of 2.2 for those taking it for more than 6 months and 2.54 for those taking it for more than a year, with p-values of 0.036 and 0.027 respectively. The main limitation of this study is that it's obviously a retrospective database study, and therefore it does not establish a causal relationship between PPI and gastric cancer. It's simply just looking at an association between PPI use and gastric cancer incidence. Also, H. pylori eradication status was not confirmed in individual patients by diagnostic tests, but by looking at the prescription of a combination of drugs that was used to treat for H. pylori infection. Also, the database did not contain any information on intestinal metaplasia, which is a known independent risk factor for gastric cancer and therefore could have been a possible confounder. So the take-home point from this study is that PPI use was associated with gastric cancer, regardless of H. pylori eradication status. Long-term PPI should be used with caution in high-risk regions for gastric cancer. So doing this journal club for the last year or so now, I think what's become evident is that treatment for NASH is really making progress with a lot of randomized trials, especially phase 2 trials of new agents for treating NASH, really gaining a lot of traction and being published in high impact journals. So this is no different. This is another New England Journal of Medicine study looking at lanifibranor, which is a pan-PPAR agonist in the treatment of NASH. This was a randomized trial. So again, NASH is a major cause of chronic liver disease. It can lead to cirrhosis, which then can lead to hepatocellular carcinoma, and is a major source of morbidity and mortality worldwide. Paroxysm proliferator activated receptors are nuclear receptors with regulatory functions in metabolism, inflammation, and fibrogenesis. This agent called lanifibranor improved insulin sensitivity and macrophage activation and reduced liver fibrosis and inflammatory gene expression in preclinical models. And it is a pan-PPAR agonist, which means that it activates all the 3 different types of PPAR receptors. The aim of this randomized trial was to look at the efficacy and safety of lanifibranor in biopsy-proven non-cirrhotic patients with NASH. So this was a phase 2b double-blind placebo-controlled randomized trial. Patients randomized into 3 groups with stratification according to the absence or presence of diabetes. So they looked at 2 different doses of lanifibranor, 1200 milligrams or 800 milligrams taken once daily, and placebo. The duration of treatment was for 24 weeks, and the primary outcome was to look at the decrease of at least 2 points from baseline at week 24 in the steatosis activity fibrosis activity component score, SAF score. This SAF score ranges from 0 to 4, with higher score indicating that the disease, indicating a more severe disease activity. So this is the disease. This is the baseline characteristics. As you can see, 83 patients were enrolled in the lanifibranor 1200 milligram group, 83 patients in the 800 milligram lanifibranor group, and 81 patients to placebo. The majority of patients enrolled in the study were Caucasians, accounting for 94, 96, and 91% of the study cohort. And if you look at the baseline SAF score, it ranged from 3.2 to 3.3. So first they looked at the primary endpoint at week 24. And as you can see, when you look at the primary endpoint, reduction of at least 2 points in the SAF score with no worsening of fibrosis. Lanifibranor 1200 milligram was superior to placebo with a risk ratio of 1.69 with a p-value of 0.07. We did not see this statistical significance in the lower lanifibranor group. When looking at the other outcome measures, also lanifibranor fared better than placebo, including the secondary endpoint of resolution of NASH without worsening of fibrosis, improvement in fibrosis, stage of at least 1 without worsening of NASH, and also the composite secondary endpoint of resolution of NASH and improvement in fibrosis of stage of more than 1. Adverse events were observed in this study, but relatively low, only 4% in all 3 groups. The most common adverse events encountered were diarrhea, fatigue, nausea, weight gain, peripheral edema, headaches, abdominal pain, dizziness, anemia, constipation, and there are some incidences of increase in LFTs, aminotransferase levels. The main limitation of the study is, again, that the majority of the study cohort comprised Caucasian patients, and a longer treatment duration and follow-up is required. Currently, the study looked at treatment period of 24 and then looked at the improvement in these fibrosis scores at the end of the 24-week treatment duration. So the main take-home point is that in this phase 2B clinical trial in patients with NASH, 1200 milligram lanifibranor resulted in a decrease of at least 2 points in the SAF, a score without worsening fibrosis in a significantly high proportion of patients compared to placebo. Next study is published in Clinical Gastroenterology and Hepatology. It's a randomized controlled trial comparing the over-the-scope clip versus traditional endoscopic treatment as the initial treatment of severe non-variceal upper GI bleeding. So rate of rebleeding after standard endoscopic therapy for severe non-variceal upper GI bleeding has been reported of up to 26%. Over-the-scope clips have been shown to be more effective than standard endoscopic therapy in reducing rebleeding in patients with recurrent bleeding from peptic ulcer disease in one study. The aim of this randomized trial by these authors was to look at over-the-scope clip versus standard treatment as primary treatment for severe non-variceal upper GI bleeding, which included patients with bleeding from peptic ulcer disease or Dullifoy lesions. So these authors conducted a fairly small randomized trial. They took patients with severe bleeding from ulcers or Dullifoy lesions and who also had major stigmata of bleeding, such as active spurting, visible vessels and clots, or lesser stigmata of bleeding, such as oozing or flat spot, but with detectable arterial flow per Doppler probe. They were randomized in a one-to-one fashion to over-the-scope clip or standard endoscopic therapy, which included epinephrine injection, hemoclips, and multipolar electrocoagulation. All patients received high-dose PPI infusion for 72 hours and then double-dose PPI for 30 days in those with peptic ulcer disease. The follow-up duration was also fairly short at 30 days. The primary outcome of this randomized trial was to look at the rate of clinically significant continued bleeding or rebleeding from index lesion within 30 days. So as you can see, this was their 30-day clinical outcome. So as you can see, this is a small randomized trial, 25 patients in over-the-scope group and 28 patients in the standard treatment group. When looking at the rate of further bleeding after treatment, the rate was 4% in over-the-scope clip and 28.6% in the standard treatment group with p-value of 0.017. When looking at the rate of severe complication, there were none in the over-the-scope group and 14% in standard treatment group with p-value of 0.049. When looking at the rate of those needing IR embolization, was 7% in standard treatment, 0 in the over-the-scope clip group, although this difference was not statistically significant. No patients needed surgery, there were no deaths. And looking at the requirement for transfusion after randomization, it was also significantly greater in the standard treatment group at 0.68 units versus 0.04 units. The length of hospitalization was also no different, however, 7 days versus 10 days. And ICU days were 2 versus 11 days, although this difference was not statistically significant, and this is probably due to the small sample sizes, not powered to detect differences in the secondary outcome measures. So these authors represented the results that we showed in the previous slide using a Kaplan-Meier curve to look at the time to rebleed. And they found that over time, looking at 30 days of follow-up, days to first rebleed, and then proportion of patients who remained free from rebleeding, the difference at the end of 30 days was significantly different, with 96% remaining rebleeding free in the over-the-scope clip group, and then 71% remaining rebleeding free in the standard group with p-value of 0.016. This looks at the rate of rebleeding within 30 days according to the stigmata of bleeding. When comparing standard treatment with over the scope, in patients who had active arterial spurting, the rate of rebleeding in the standard group was very high at 43%, with 0 in over the scope clip group. In patients who had non-bleeding but visible vessel, the rate was 25% in the standard group versus 8% in the over the scope clip group. In patients who had an adherent clot, 50% of these patients in the standard treatment rebled compared to 0 in the over the scope clip. Overall, looking at patients with high risk stigmata of rebleeding, the rate was 35% in the standard treatment group versus 6% in the over the scope clip group. So there are several limitations to this randomized trial. I think the most obvious is the small sample size, only 25 patients in 25 and 28 patients respectively in the two groups. Also, the follow-up period is very short, only 30 days of follow-up. And also, this study was conducted at UCLA, Tertiary Referral Center, who are experts in the management of upper GI bleeding, and this may have affected the generalizability of the study results. So the take-home point is that the over-the-scope clip significantly reduced the rate of rebleeding, the rate of severe complications and blood transfusions in patients with non-variceal upper GI bleeding compared to standard endoscopic therapy. This is our last study. This is a randomized trial published in Gut. It's a multi-center prospective randomized study comparing the diagnostic yield of colon capsule endoscopy versus CT colonography in screening population. It's called the TOPAZ study. So it's a fairly interesting randomized trial, I thought, because so far there haven't been any clinical trials directly comparing two non-colonoscopy modalities of screening for colon cancer in an average risk population. So they compared colon capsule endoscopy and CT colonography. So colon capsule endoscopy involves ingestion of a disposable capsule designed to obtain video images during its natural progression through the GI tract. And it's currently approved in the United States in patients who have an incomplete colonoscopy, but with adequate bowel prep, and who are at major risk for colonoscopies or moderate sedation. CT colonography. Can everybody please kindly mute their microphone? Can everyone just double check, because I can hear some background noises. Thank you. CT colonography is currently recommended by ESGE as a primary test on an individual basis in a population without an organized fit-based population screening program. And as mentioned earlier, so far no studies have compared these two techniques in average risk colorectal cancer screening population. And the aim of the study was to compare the performance of colon capsule endoscopy device with CT colonography in average risk colon cancer screening population. So this was a randomized trial, multi-center trial involving 13 centers. They included all patients between the ages 50 and 75 who had average risk for colon cancer. They were randomized in a 1-to-1 ratio to either colon capsule endoscopy or CT colonography, and everyone then underwent a follow-up colonoscopy within 5 weeks of either capsule or CT. The primary outcome measure was the diagnostic yield of detecting polyps at least 6 millimeters in size. So these are the baseline characteristics. So 145 patients were enrolled in the capsule group, 141 in the CT group. And as you can see, As you can see, there were significantly more females than males enrolled in the study. There was some difference between the two groups in terms of the BMI, the smoking history, race, ethnicity. However, there was no difference between the two groups. Now, looking at the primary outcome of the ability to detect polyps at least 6 millimeters in size, as you can see, when comparing capsule to CT, the rate of being able to detect polyps greater than 6 millimeters in size was 31% for capsule versus only 8% for a CT. And the authors do state that this was statistically significant. This is the diagnostic, the operating characteristics of the individual modalities, the capsule versus CT for detecting polyps at least 6 millimeters in size. And as you can see, the sensitivity for capsule for detecting polyps more than 6 millimeters was 79%. The specificity was 96%. But if you look at the CT colonography, the sensitivity is very low. It's only 27%, although the specificity was fairly high. Then looking at the secondary outcome measure of detecting polyps at least 10 millimeter in size, as you can see, the detection rate for capsule was 13.5% versus 6.3% for CT colonography. Again, the operating characteristics for capsule versus CT, the sensitivity was better than for detecting polyps at least 6 millimeters in size, with sensitivity of 86% and specificity of 98%. Sensitivity was for CT was better compared to the ability to detect smaller polyps. However, it's still very low, with sensitivity of only 50%, but good specificity of 99.1%. So the main take-home point from this randomized trial were as follows. Colon capsule endoscopy appeared to be superior to CT colonography in an average risk population for identifying polyps at least 6 millimeters in size, and was non-inferior to CT colonography for polyps at least 10 millimeters in size. But it's important to remember that both capsule and CT colonography had lower sensitivities than colonoscopy for polyp detection, although the diagnostic yield for capsule was comparable with colonoscopy. And therefore, in patients who are unable to undergo colonoscopy or after an incomplete colonoscopy, capsule endoscopy rather than CT colonography should be considered the first-line imaging test after incomplete colonoscopy. So this is our journal recap. So first study from South Korea showed that PPI use was associated with gastric cancer, regardless of H pylori eradication status, and long-term PPI should be used with caution in high-risk regions for gastric cancer. Second study, published in the New England Journal of Medicine, showed that the 2B clinical trial showed that in patients with NASH, the 1200 milligram lanifibranor dose resulted in a decrease of at least 2 points in the SAF score without worsening fibrosis in a significantly high proportion of patients compared to placebo. Over the scope clip, significantly reduced rate of rebleeding, severe complications, and blood transfusion in patients with non-variceal upper GI bleeding compared to standard endoscopic therapy. However, this randomized trial had small sample sizes, and again, additional training is required for over-the-scope clips. Next, in a multi-center randomized trial comparing colon capsule endoscopy with CT colonography. Colon capsule endoscopy was superior to CT colonography in an average risk population for the identification of colorectal polyps at least 6 millimeters in size, and non-inferior to CT colonography for polyps at least 10 millimeters in size. Both capsule endoscopy and CT colonography had lower sensitivities than colonoscopy for polyp detection, although the diagnostic yield for capsule endoscopy was comparable with colonoscopy. Therefore, capsule endoscopy should be considered the first-line imaging test after an incomplete colonoscopy rather than CT colonography. So we're ending a little early today, so everyone can carry on with their day or evening. Our next journal club will be 1st of December, 2021, which is the first Wednesday of December. Thank you so much for joining us this morning or this evening, wherever you are in the world. And I just wanted to remind everyone that we are having a Florida Digestive Disease Update. It's an in-person conference just over the weekend, December 4th and 5th, on a Saturday and a Sunday in Orlando at the Gaylord Palm Resort Convention Center. Details are on our website. It should be an absolutely fantastic weekend, lots of education and hopefully lots of socializing. We have great speakers, so do please join us if you can. The weather is really also wonderful in Florida in December. All right. So thank you very much, everyone. Hope you have a wonderful day. Okay, thank you.